Usually, a clinical guideline is treated like a reinforced concrete levee. You stand behind it, you follow the established protocols, and you're safe from the storm of malpractice liability.
Right, exactly. It's meant to be this safe harbor. You follow the rules, you document your steps, and ideally, you don't get washed away in a courtroom.
Exactly. But when you step into the world of modern obstetrics, that levee starts to look remarkably fragile. Right now, global healthcare initiatives, led by the World Health Organization, are pushing incredibly hard to lower cesarean section rates back down to an evidence-based optimal threshold of 10 to 15%.
Yeah, because we know that on a population level, too many surgeries lead to worse maternal outcomes. But I mean, this creates a profound structural tension for the individual doctor.
It really does. Which brings us to the core question of our discourse today. Grounded in the WHO's Robson Classification Implementation Manual and the 2026 Consolidated Master Evidence Reference. Does adhering to these new clinical guidelines actually reduce a physician's malpractice liability?
Or does stepping back, reducing those surgical interventions, actually expose obstetricians to just catastrophic medical legal risk? Because to me, it's the absolute definition of a clinical and legal catch-22.
Right. Well, my stance is that strict adherence to standardized clinical frameworks, specifically things like the Robson 10-group classification system and the modern consensus on when active labor truly begins, provides a robust, evidence-based legal shield. I believe integrating these protocols fundamentally protects doctors and ultimately reduces their malpractice vulnerability.
I completely understand the clinical logic there, but I just see the reality on the ground differently. Without systemic tort reform, the immediate punitive medical legal environment makes defensive medicine a highly rational survival strategy. The legal system heavily penalizes vaginal birth complications while treating C-sections as, essentially, a legally defensible safe harbor.
Well, let's lay out our foundational positions, and I want to start by looking at where the real legal threat actually hides. Because the prevailing anxiety is always focused on the immediate birth, right? The fear of a delayed intervention.
Right, the immediate neonatal outcome.
Exactly. But the greatest medical legal threat in obstetrics today is actually the downstream consequence of unnecessary primary C-sections. We have to look at how surgical complications compound catastrophically over a woman's reproductive lifespan.
The compounding risk is certainly the crux of the clinical argument. I'll give you that.
Right, and let's unpack why that happens. When you perform a C-section, you leave a scar on the uterus. If that patient gets pregnant again, there's a risk that the new placenta will implant over that scar. The risk of placenta apravia jumps from 1% after one prior C-section to 10% after 3 or more.
Wow, that's a massive jump.
It is. But the truly devastating complication is placenta accreta. Because the uterine tissue is scarred, the placenta aggressively invades and attaches deep into the uterine wall. Accreta complicates nearly 67% of those pravia cases following 3 or more surgeries.
Wait, 67%?
Yes, 67. And in the delivery room, that translates to massive, life-threatening obstetric hemorrhage, emergency hysterectomies, and severe maternal morbidity. So, by utilizing strict institutional auditing alongside updated standards on prolonged labor, we create an impenetrable standard of care.
To protect from the old lawsuits.
Exactly. This framework protects physicians from the archaic, failure-to-progress lawsuits that drove everyone to overoperate in the first place.
I come at it from a different way. The physiological mechanisms you just described, the scar tissue, the aggressive placental implantation, the massive hemorrhages, those clinical realities are undeniable. But the physiological mechanism is completely divorced from the legal mechanism.
How so?
Well, those statistics don't dictate how liability functions in real time. Clinical guidelines fail to protect doctors in a courtroom that is fundamentally driven by hindsight bias, particularly regarding neonatal outcomes. If you look at the qualitative research, it shows overwhelmingly that the fear of litigation is the primary driver of C-section overuse.
But shouldn't the fear of a massive hemorrhage from placenta accreta counterbalance that fear?
In a perfectly rational system, maybe. But the long-term maternal risks are years down the line. The immediate legal threat of a depressed or brain-injured newborn forces the physician's hand right then and there.
That makes sense. But
think about the precise calculus of defensive medicine at 2 in the morning. an unnecessary surgery is viewed by the legal system as a defensible action. You intervened. Conversely, an adverse neonatal outcome following a delayed intervention results in an immediate, indefensible malpractice suit. The jury just sees a doctor who waited too long.
But pushing the timeline of labor back isn't just a suggestion anymore. It's a structural change in the standard of care. Which brings us to our first major point of contention, the idea of a guideline providing a legal shield versus that frontline fear. Let's talk about the shift away from the Friedman curve.
Ah, yes, the old train schedule for labor.
Exactly. For decades, obstetrics was governed by this curve, which defined active labor as starting at 3 to 4 centimeters of dilation. It expected the cervix to dilate perfectly linearly 1 centimeter per hour.
Right, and if a patient deviated from that schedule by even an hour, the doctor felt compelled to intervene with a C-section to avoid being sued for failure to progress.
Precisely. But modern data from over 62,000 deliveries completely dismantled that schedule. The consensus redefined active labor as starting much later, at 6 centimeters. They proved that taking over an hour to go from 4 to 5 centimeters is just normal physiology, not a pathology requiring a scalpel.
I mean, clinically, yes, the data absolutely supports that.
And adopting these new standards yielded a massive population-level effect. A 30% reduction in intrapartum C-sections for induced first-time mothers. My point is, when an entire hospital integrates this, stepping away from the Friedman curve is no longer a rogue decision. You are standing behind the fortress of modern consensus.
I'm sorry, but I just don't buy that. Let me tell you why. If these codified guidelines provided the impenetrable legal shield you're describing, we would see massive sustained behavioral shifts across the board.
We are seeing shifts, though.
Not enough. Recent data shows a 15-year stagnation in United States C-section rates, despite the wide dissemination of these exact guidelines.
I see why you think that, but let me give you a different perspective. If an entire hospital adopts these modern guidelines, aren't you conflating the legal risks of the 1990s with the evidentiary protections of 2026? If the consensus explicitly says you can wait, the plaintiff's attorney has no ground to stand on.
They absolutely have ground to stand on because plaintiffs' attorneys don't argue the general consensus. They attack the application of the guideline in the specific edge case.
Give me an example of how that happens in a courtroom.
Okay, a guideline states a physician may allow for extended pushing. But let's say the fetal heart rate monitor starts showing a category 2 tracing. This isn't a flat line, it's a gray area. It means the heart rate is ambiguous. It's notoriously subjective.
Right, it requires interpretation.
Exactly. If the doctor follows the general guideline to wait and the neonate is born with a low APGAR score indicating distress, the attorney is going to weaponize that heart rate monitor. They'll argue the physician rigidly adhered to a generalized hospital guideline while ignoring the specific distress of the patient right in front of them. The guideline transforms into a weapon.
But waiting longer inherently brings up the next bottleneck, which transitions us to our second point of contention, the atrophy of operative vaginal delivery, or OVD, and the risks of a trial of labor after cesarean, TOLAC.
And this is precisely where the legal terror takes over. We are currently facing a crisis in OVD. Clinical competency in using forceps and vacuum extraction is rapidly declining across high-income countries.
And you're arguing that's driven by medical legal pressure.
It is directly, measurably driven by it. It's a self-perpetuating cycle. A physician is terrified of a lawsuit from an OVD complication, like a fetal skull fracture, so they avoid it entirely and default to a C-section. Because they avoid the procedure, the hospital loses that institutional skill over time.
Junior doctors never learn how to safely apply forceps.
Exactly, and that lack of skill generates more C-sections for prolonged pushing. It's an issue of exposure. Look at vaginal birth after cesarean, or VBAC. The data shows it's safe, but it still carries roughly a 0.47% risk of uterine rupture. Less than 0.5% is tiny on a spreadsheet, but a rupture is a catastrophic nightmare in the courtroom.
It's an undeniably severe event.
Right. And if you are the individual provider who made the call to manage that labor, the fact that you are trying to improve the hospital's systemic statistics does not insulate you. You are the one facing the multi-million-dollar settlement. The risk is completely asymmetric.
That's an interesting point, though I would frame it differently. I'll absolutely concede the acute severity of a uterine rupture. It's terrifying. But we have to reframe the statistical reality of what we are actually doing by avoiding these procedures.
How so?
Letting forceps skills atrophy because you're afraid of a lawsuit is like disconnecting the fire alarms because you hate the noise. You avoid the immediate headache, but you're guaranteeing the house burns down later in the form of placenta accreta in Robson Group 5.
But the doctor who disconnects the fire alarm isn't the one who gets burned.
But the patient does. And the liability still exists. It just changes shape. By avoiding a vacuum extraction today, you force that patient into a primary C-section. That guarantees her next delivery will be a repeat C-section.
True, the risk does shift.
Let's look at comparative mortality. The maternal mortality for a planned repeat C-section is over 13 per 100,000. For a planned VBAC, it's less than 4. By avoiding OVD or VBAC due to fear, we aren't eliminating liability. We're just shifting it to massive hemorrhage and blood clots later on.
You're accurately describing the statistical truth, but statistics do not write indemnity checks. You have to look at how the law perceives action versus inaction.
Go on.
The physician is penalized for acts of commission, applying forceps or attempting a VBAC, far more aggressively than acts of omission, which is just defaulting to a repeat surgery. If a baby is injured during a forceps delivery, it is viewed as an iatrogenic injury, a harm directly caused by the physician's active hubris.
But that's exactly why we can't leave the individual physician isolated to make these decisions, which brings us to our third area of debate: governance, second opinions, and institutional indemnity.
I'm highly skeptical that governance alone can shield a provider without changing the laws themselves.
Well, let's look at the mechanisms. The evidence strongly suggests systemic governance can absorb that liability. The solution is structured clinical auditing, specifically using the Robson classification.
Right, sorting patients into the 10 groups.
Exactly. By isolating the data, hospitals can find exactly where unnecessary surgeries are happening. When you combine this auditing with a policy of mandatory second opinions for non-emergency C-sections, the dynamic changes completely.
How does adding administrative hurdles lower the legal risk, though?
Because it distributes the responsibility. Look at the California Maternal Quality Care Collaborative, the CMQCC. They achieved a nearly 7% absolute decline in C-section rates for low-risk first-time mothers.
Through institutional quality improvement?
Yes. If a doctor wants to perform a C-section for a stalled labor, they have to consult a senior peer. They review the fetal heart rate and consensus guidelines together. When you mandate that second opinion, the solitary physician isn't making an isolated choice at 2 in the morning. They're enacting a shared, institutionally indemnified decision.
That's a compelling argument, but have you considered that these governance structures only work if they are accompanied by true tort reform?
In what sense?
You're describing a medical utopia where peer review protects you from a subpoena, but it doesn't. If the outcome is bad, the plaintiff's attorney isn't going to praise the collaborative process. They're just going to sue both doctors instead of one.
I'm not convinced by that, because you're assuming the adverse outcomes remain the same. The collaborative models inherently improve the safety of the care being delivered.
But we have data showing what happens when you implement governance without legal immunity. When health systems apply simple regulatory pressure to lower rates, they can actually cause measurable harm, like increased postpartum hemorrhage.
Wait, really? How does that happen?
Because you aren't removing the physician's liability, you're just forcing them to practice closer to the edge of danger. A doctor terrified of being flagged on a Robson audit waits longer and longer during fetal distress until the neonate is severely compromised.
But that's analyzing poorly designed interventions. Successful models like California's don't just put a metric on a dashboard. They provide comprehensive infrastructure.
Systemic solutions, basically.
Exactly. They implement readiness protocols, recognition of hemorrhage, rapid response teams. It isn't about pushing doctors to wait until a baby is compromised. It's about giving them the clinical confidence to recognize that a long labor is normal physiology. The liability is managed because the care is undeniably better and less prone to individual panic.
Better care on a population level, absolutely. But we keep circling back to the individual provider, standing at the bedside.
Right.
If that baby is born with severe brain damage, the expert witness will tell a jury, The doctor ignored clear distress just to satisfy a hospital C-section quota. Until we change medical malpractice laws, defensive medicine remains a perfectly rational response.
Well, to summarize my position in light of this incredibly nuanced discussion, I believe the path forward must be paved with data and standardized frameworks. The downstream clinical consequences of surgical overuse, the aggressive placenta accreta, the cascading risks are far too devastating to ignore.
And to summarize my stance, I believe clinical guidelines are not a substitute for actual legal reform.
Right, but modern rigorous protocols, like Robson auditing, provide both the framework and legal defense to reverse this trend safely. When integrated properly, they create a protective consensus for frontline providers.
But until governments enact genuine tort reform, those frontline providers bear an ultimate asymmetric risk. As long as the legal system treats an unnecessary surgery as a safe, defensible choice, obstetricians will continue to operate to protect their patients and their livelihoods. You simply cannot cure a legal pathology with a clinical guideline.
I think it's clear we share a fundamental point of convergence here. We both agree the current medical legal environment places an unfair, genuinely crushing burden on obstetricians. Systemic support is absolutely vital for any clinical reform to succeed.
Agreed. Physicians shouldn't have to choose between evidence-based medicine and their own professional survival. It requires a holistic shift in both healthcare administration and our jurisprudence.
Exactly. Analyzing healthcare through both a clinical and legal lens reveals profound complexities. The tension between best practices and legal fear is a deep structural issue worth further exploration. Thank you for joining us on The Debate.